Hello and welcome to the CAP Today webinar for Wednesday, September 24th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host, and I'll moderate a question and answer session after today's formal presentation. Today's webinar is entitled Unlocking Fertility Insights. The power of anti-Müllerian hormone, or AMH, in women's reproductive health. This is an important webinar and it's very timely, and it's made possible, it's important that you know, by a special education grant from Siemens Healthineers. We want to acknowledge Siemens for their support and help in helping us to bring you this very important program and this wonderful session with expert speakers. We're going to feature two speakers today, each one an expert in her field. Our first speaker will be Dr. Wendy Vitek. She's a board-certified reproductive endocrinologist at Boston IVF's Syracuse, New York Fertility Center. She's a superbly trained physician. She did her medical degree at the University of Rochester, OBGYN residency at McGee, and did a fellowship in this particular subject matter at Brown. And we're just delighted to have her with us today. After we hear from Dr. Vitek, we're going to hear from Dr. Shirley Li, an MD and PhD. She's the associate professor of clinical professor in the Department of Pathology and the director of clinical pathology services, co-directing the clinical chemistry and toxicology laboratory at The Ohio State University, which is always a pleasure to say. And we say it a lot in the fall when the football season's on, as you all know. And in particular, then that's in Columbus, Ohio. It goes without saying. Before we begin, I do want to make a couple of little housekeeping hints. You're going to see on your screen a box where you can make comments and post questions. We'll deal with those in the question and answer session after the presentations. In that same box, though, if you're having any technical problems, either with the slides or with the audio, you can put those in there. We have live attendants at all times during today's session who can help you. It's important that you know we plan to post the full slides and audios of today's presentation at captodayonline.com in about a week or so after review. You can expect to see some email both from us and from our sponsor, Siemens. So look for that in your inbox. Finally, as always, I need to remind you that CAP Today does not endorse any product or services that may be mentioned in today's presentation. Any remarks of mine are purely personal and not to be taken as policy of the CAP Today or the College of American Pathologists. And now we're about to begin, and I'm bringing you an invited special guest. Dr. Mark Borgman of Siemens is going to briefly introduce today's session. Dr. Borgman is a PhD and a diplomate of the American Board of Clinical Chemistry. He's a great expert in this area, and Siemens is lucky to have him, and we're lucky to have him introducing our session. I should let you all know in the audience, the session you're about to hear has been pre-recorded in its entirety. All the speakers are with me now, and they will join me live when the taped session ends, and then we'll have live Q&A. So pay attention and bring us your questions and comments. And with that, let's go ahead now and run the presentation. Thank you.
Thank you, Bob. Good morning, good afternoon, and thank you so much for joining this webinar today discussing AMH. I am Dr. Mark Borgman, a medical sciences partner with Siemens Healthineers. We have two great speakers for today's webinar, where we will discover the clinical importance of AMH testing and how results support informed fertility decisions. We will also learn how this assay performs analytically and clinically, allowing labs to implement AMH testing with confidence. And of course, we will have the opportunity to ask questions of our presenters. Siemens Healthineers is committed to providing high-performing laboratory diagnostics for women's health, as you will see today with AMH, as well as our entire robust test menu to deliver diagnostic insights throughout the patient journey. We hope that you will find the content today highly relevant to your laboratory, as well as to your physician practice. As noted, speaker disclosures are listed here. And with that, I am pleased to hand off to our first presenter, Dr. Wendy Vitek.
Hi, thanks for the introduction. I'm excited to share with you how anti-Müllerian hormone, or AMH, has transformed our ability to understand ovarian reserve and guide fertility care. Over the next 15 minutes, I'll walk through the clinical perspective, what AMH is, why it matters, and how we can use it to personalize treatment decisions. I'll also highlight real-world case studies that illustrate how this biomarker supports both patients and providers in navigating fertility options. Here's where we're headed today. We'll begin by looking at the modern fertility landscape and the challenges we face with delayed childbearing. Then I'll explain what AMH is and how it correlates with ovarian reserve. Next, we'll look at the Siemens Healthineers AMH assay as a solution that addresses key clinical need. From there, we'll dive into case studies that show how AMH results guide our clinical decision-making. And finally, we'll wrap up with key takeaways that tie it all together. As many of you know, more women are delaying childbearing. This means we're seeing a growing number of patients who are seeking fertility evaluation and treatment. IVF cycles have doubled between 2013 and 2022, and now about 1 in every 37 babies in the US is conceived with IVF. Importantly, success rates with IVF are still strongly tied to age, which makes accurate assessment of ovarian reserve critical. Ovarian reserve is one of the key factors we consider in our fertility assessment. The number of oocytes or eggs declines steadily with age and correlates with reproductive potential. This is why women in their mid to late 30s often present us with concerns. Tools like anti-Müllerian hormone testing and antral follicle count help us quantify ovarian reserve. But it's not just about numbers, it's also about setting realistic expectations and guiding treatment pathways. Traditional markers like FSH, follicle-stimulating hormone, and estradiol are cycle-dependent and late indicators of diminished ovarian reserve. That means that the blood test, FSH and estradiol, typically have to be tested on cycle day 2 or 3 in order to be interpreted correctly. Antral follicle count is also cycle dependent, meaning it should ideally also be done on day 2 or 3, and it requires a transvaginal ultrasound, which some would consider invasive. Anti-Müllerian hormone stands out because it's cycle independent, non-invasive, and it also provides an earlier prediction of diminished ovarian reserve when compared to FSH and estradiol. It's cycle independent, meaning it reflects the wave or pull of antral follicles, which should always be developing during the menstrual cycle and between menstrual cycles. Thus, AMH can be checked at any point in the month. It doesn't have to be tied to cycle day 2 or 3 like FSH, estradiol, and antral follicle count. For these reasons, it's the biomarker of choice for both clinical and research settings. AMH is secreted by granulosa cells in small antral follicles and plays a role in regulating follicle recruitment and development. Clinically, it reflects the size or number of antral follicles and is a surrogate marker for the quantity or number of eggs available in a given time. A key distinction is that AMH measures quantity, not quality. This is critical in counseling. A low AMH doesn't exclude pregnancy potential, and a high AMH doesn't guarantee a pregnancy. One challenge in clinical practice has been the lack of assay standardization. Results could vary significantly depending on the platform. The Siemens Italica and Centaur AMH assays were developed to meet this need. They offer a broad range, high reproducibility, and automation that reduces human error. Results are aligned with the widely used Beckman assay and can be turned around in about 28 minutes, making them clinically actionable for time-sensitive care. Now that we've reviewed what AMH is and how the Siemens Healthineers assay addresses key clinical need, let's look at how these results come together in day-to-day practice. I'll walk you through several real-world cases that show how AMH values directly influence clinical decisions, patient counseling, and outcomes. Here's the first case. A 38-year-old with prior failed stimulation attempts has an AMH of 0.6, consistent with diminished ovarian reserve. Clinically, we expect a lower egg yield and a higher risk of cancellation without a tailored plan. Our goals are to maximize mature oocytes while minimizing last-minute protocol changes and medication orders. Based on the AMH, we recommend a microdose Lupron flare protocol with high-dose gonadotropin stimulation. We monitor closely through ultrasound and estradiol levels, adjusting doses to avoid plateaus in growth. For final oocyte maturation, we typically use an HCG trigger once there are at least 2 or 3 follicles measuring at least 17 millimeters and an adequate group of intermediate follicles developing behind the dominant follicles. Counseling focuses on realistic expectations. We may retrieve a small group of eggs, but each mature egg has potential. We also discuss the likelihood of needing more than one cycle to reach the embryo goal. In this case, the cycle proceeds successfully with retrieval of mature eggs or oocytes, fertilization, and embryos available for transfer. The key takeaway is that using AMH upfront streamlines protocol selection and medication planning, reducing costly last-minute changes or cycle cancellation. This is in contrast to a case with a high responder. In this example, we have a 28-year-old with PCOS who has an AMH of 6.2, indicating a large antral follicle pool and a high probability of a robust response. Here, the priorities are optimizing oocyte yield while reducing OHSS risk. OHSS refers to a rare but serious complication called ovarian hyperstimulation syndrome. Based on the AMH, we select a GnRH antagonist protocol with a low starting dose of gonadotropins. We monitor follicle growth and estradiols, and as we see the cohort starting to grow, we add in the antagonist. That allows us to pick a safe trigger for the final step, which is oocyte maturation. When we're working with an antagonist protocol, we can use a GnRH agonist trigger or leuprolide acetate, which is key to reduce the risk of ovarian hyperstimulation syndrome. We proactively mitigate this risk as well by using other medications such as cabergoline after trigger, freezing all the embryos, and other medications include using a GnRH antagonist after the retrieval to further reduce the risk and get the ovaries back to their baseline quicker. In this case, she produces an optimal number of mature oocytes and cryopreserved embryos. And most importantly, ovarian hyperstimulation was avoided by using AMH to choose the correct protocol, a low starting dose of gonadotropins, and the GnRH agonist trigger. Next, we'll look at a case where AMH is uncovering a surprise. In this case, a 32-year-old presents to her OBGYN asking about freezing her eggs, but she's thinking about waiting a couple of years. The OBGYN counsels her on ovarian reserve testing and finds that the patient has a normal value for her day 3 FSH and estradiol, which in and of itself would be reassuring, yet her AMH reveals a different clinical picture. Her AMH is 0.8, which is lower than expected for age. This unexpected finding is a starting point for a difficult conversation that the OBGYN can have with the patient about the possibility of diminished ovarian reserve. This allows the patient to make a more informed decision and be referred to an REI for oocyte banking. That ultimately this patient decides to pursue egg freezing, and she does so sooner than later, showing how having the AMH level can be an earlier marker of diminished ovarian reserve and allow both the patient and her care team to make a timely decision around her desire to freeze eggs now instead of waiting until it's possibly too late. Finally, another example of the power of AMH is in the setting of oncofertility. In this example, there's an 18-year-old who's been diagnosed with an osteosarcoma, and her cancer treatment will include ovarian toxic chemotherapy. She desires future fertility and wishes to freeze her eggs prior to starting chemotherapy. And the goal is to start chemotherapy as soon as possible, ideally within the next 2 weeks. An AMH level is drawn and quickly resulted at 2.5. This gives us a sense of her normal for her age ovarian reserve and allows us to quickly determine which protocol would be optimal for her egg freezing cycle. In this setting, we're also able to use random start IVF protocols, which means starting stimulation in the luteal phase instead of waiting for her period and doing a typical follicular stimulation. Based on her AMH, we pick moderate dose stimulation, and we coordinate her care closely with her oncology team to ensure that we complete this important aspect of her care in a timely manner. The quick turnaround of the AMH assay supports same-day counseling and protocol planning, enabling retrieval and cryopreservation before the 2-week chemotherapy start. This highlights how lab capabilities and clinical coordination directly impact fertility preservation without compromising her prognosis for her cancer care. So to bring it all together, AMH is the preferred biomarker for ovarian reserve because it's cycle independent, meaning it can be checked at any point in the menstrual cycle. It's an earlier indicator of change in oocyte quantity compared to traditional markers like FSH and estradiol. And it's non-invasive, unlike antral follicle count, which is determined via transvaginal ultrasound. When integrated into care, it allows for personalized treatment planning, which optimizes outcome, reduces costs, and enhances patient safety. The Siemens Healthineer assay meets the clinical need by delivering consistent, reproducible, and actionable results. Ultimately, this supports both physicians and patients in making informed and timely decisions. With that overview of the clinical perspective, I'd like to turn it over to my colleague, Dr. Shirley Li. Dr. Li will dive into the laboratory side, walking us through how AMH is measured, why assay differences matter, and how Siemens Healthineers has worked to improve consistency and reliability in results.
Okay, thank you, Dr. Vitek, for the excellent presentation. I really enjoyed your insights in the clinical application of AMH, and I have learned a lot from your talk. Building on that, I will be shifting the focus slightly My presentation today will examine both the analytical and clinical comparison of AMH testing across automated platforms. AMH immunoassays are now widely used for assessing ovarian reserve and play an important role in several reproductive conditions where understanding the size of the ovarian reserve is clinically meaningful. While AMH could be measured by both manual and automated immunoassays, the automated platforms generally demonstrate superior analytical performance. While what I'd like to share with you today is how this modern automated assay platform, not only in terms of laboratory precision, but also in how well they support real-world clinical needs. In short, we will explore how automation is shaping AMH testing and helping us bridge the gap between the lab and the clinical practice. Before we dive into the data, I'd like to walk you through the learning objective for today's session. I will describe the key methodologic differences among the major automated AMH assays, including the Siemens Advia Center and the Teleca IM, the Beckman Counter DXI 600 Access, and the Roche Cobas Alexis EA01. I'll discuss potential source of variability across platforms, things like assay design, antibody specificity, and possible interference that can all contribute to differences in AMH measurement. Then I will compare the clinical performance of these assays, looking at sensitivity, specificity, and how cutoff selection may impact clinical interpretation. And finally, I'll discuss the implications of this variability, what it means for interpreting AMH results, especially in the context of fertility assessment and patient management. Before we go into the assays discussion, I'd like to briefly review the biology of AMH. So AMH is a member of the transforming growth factor beta superfamily. Structurally, it's a 140 kilodalton hormone dimeric glycoprotein made up of two identical subunits linked by disulfide bonds. The AMH gene encodes a precursor protein known as pro-AMH, which is 560 amino acid long. And this precursor is processed into pro-AMH, which by itself does not bind to the AMH receptor. Through further proteolytic cleavage, pro-AMH is converted into the bioactive form called AMH-NC. This bioactive form is a complex of two fragments, the N-terminal and the C-terminal, that are associated non-covalently. In circulation, we primarily see two forms, pro-AMH and AMH-NC, presented in different ratios depending on the individual. Importantly, the immunoassays that are currently available detect both of these circulating forms. So when we measure AMH clinically, the reported value is actually a composite of both pro-AMH and the bioactive AMH-NC. This biological background is important to keep in mind as we compare assays, because it helps explain why different methods can sometimes produce different results. One of the major challenges with AMH testing has been the lack of international standardized reference material. Without a common calibrator, it is very difficult to directly compare results across different assay platforms. To address this, the World Health Organization, WHO, undertook a large international collaborative study They developed a reference material purified from the culture media of a stable human ovarian cancer cell line. This preparation, known as WHO code 16/190, that material was distributed to participating laboratories around the world. In the study, labs ran this reference material using their own AMH immunoassays. In total, 21 different assay methods were tested, which covers both manual and automated systems. The results, however, showed substantial variability between assays. This wasn't entirely unexpected. AMH is a large, complex glycoprotein, and it circulates in the blood in both precursor and processed forms. Meanwhile, the WHO reference material is a purified recombinant preparation, and it's not fully clear how well this preparation reflects the heterogeneous forms of AMH that are naturally present in serum. So, while WHO study represented an important step toward harmonization, it also highlighted the fundamental biological complex of AMH and why achieving full comparability between assays remains such a challenge. Now that we've looked at the biological complexity of AMH and the challenges we face with developing a reliable international reference material, it's important to ask, what does this mean in practice for the assays we use every day? To answer that, there have been two independent studies that specially investigated the analytical and clinical variation of AMH testing across different automated platforms. These studies give us valuable insights into just how consistent or inconsistent results could be when measured on different platforms. They also help us understand the implication for both laboratory practice and clinical decision-making. In the next few slides, I will walk through the details and data from those studies so we could see exactly where the differences are and what that means for how we interpret AMH results in patient care. On this slide, I have summarized the 4 major automated AMH assays currently in use. They are Beckman counter access DXI assay, the Siemens Italica and Center assay, and the Roche Alexei EOL1 assay. Each of these use a 2 monoclonal antibody design with a chemiluminescent immunoassay method. Their analytical measuring range are fairly similar, running from about 0.03 to 24 nanogram per milliliter, depending on the platform. For context, there is also a manual ELISA assay from AMH Labs, which has a narrow analytical measurement range. But since our focus today is on automated testing platforms, I won't be covering that assay in detail. Finally, it's important to note that across platforms, the clinical decision point of 1.77 nanogram per milliliter is commonly applied in fertility and ovarian reserve assessment. So while these assays look broadly comparable, subtle differences in their design and measuring range could matter, especially for patients whose AMH levels are close to the lower detection limit. In our most recent analytical comparison study, we looked at how AMH results compared across the 3 major automated platforms. We collected 120 residual patient serum samples at Yale New Haven Hospital, covering the full reportable range of AMH. these samples were aliquoted and were retested on the Beckman and Roche assays at Yale and on the Siemens assays at the Ohio State University. When we analyzed the data, we found that Siemens show a slight positive bias compared to the Beckman, with a slope of 1.07 and an R-square of about 0.98. Importantly, the blend-Altman plots showed that this difference was consistent, which means it did not vary by AMH concentration. This finding was also consistent with an earlier independent publication, which demonstrated a strong correlation between the Siemens and the Beckman assays, with a Kendall's tall correlation coefficient of 0.9. Here on the slide, you can see the scatter plots using passing-Bablock regression, which gives a slope of 1.0, which is essentially a perfect fit. The blend-Altman plots from both our study and the earlier publication also show very similar bias, reinforcing that the difference we observe are reproducible across the studies. So overall, while there are slight systematic differences between platforms, they remain highly correlated and consistent across independent studies. Now let's turn to the Roche analyzer. In contrast to Beckman versus Siemens comparison we just saw, the Roche system showed a notable negative bias when compared with Siemens. Especially the regression analysis gave us a slope of 1.4 and an R-square of 0.97. When we look at the blend-Altman plots, we saw something different from before. Here, the bias was not consistent. Instead, there was a positive correlation between the difference and the AMH concentrations. In other words, the higher the AMH level, the larger the discrepancy between Roche and Siemens results. This finding is consistent with an independent study which showed a moderate correlation between the Siemens and the Roche assays with a Kendall's tall correlation coefficient of 0.7-ish. Here on the slide, the passing-Bablock regression again shows a slope of around 1.4, and the blend-Altman plots demonstrate a bias of 62%. But this difference was consistent. It did not vary by AMH concentration. So taken together, these results highlight a key issue. While Siemens and Beckman align very closely, the Roche platform consistently reports results that deviate. Next, let's look at the comparison between Roche and Beckman. Here, the Roche analyzer again showed a negative bias relative to Beckman. The passing-Bablock regression gave us a slope of 1.3 and an R-square of 0.96. The blend-Altman analysis reinforced this finding, showing that the difference in AMH results became larger at higher concentrations. So just as we saw in the Roche versus Siemens comparison, this bias is not consistent across the measurement range. In the independent study, the relationship was very similar. The slope was 1.4, and the moderate correlation with Kendall's tall coefficient of 0.75. Importantly, these results are within expectations. Given that Siemens assay correlates almost perfectly with Beckman, it follows that the deviation we are seeing is largely driven by the Roche assay. So no matter if we compare Roche versus Siemens or Roche versus Beckman, we see a consistent pattern of negative bias that becomes more noticeable at higher AMH concentrations. Now that we've seen the analytical variations across platforms, the next important question is, do these differences actually impact clinical practice? To address this, I'll highlight a very well-designed study. In this study, 532 women between the age of 22 and 45 were enrolled. All participants were being evaluated for ovarian reserve, and strict inclusion and exclusion criteria were applied to make sure the study population truly represented the intended use of AMH assays in clinical practice. That is, women of reproductive age seeking ovarian reserve assessment prior to starting fertility therapy. Let's take a closer look at the study population. Of the 532 women enrolled, about 48% were classified as having normal to diminished ovarian reserve, defined as AFC of 15 or less. The remaining of 52% had higher ovarian reserve with AFC above 15. In terms of demographics, the majority of participants were white, and most were not Hispanic or Latino. The percentage of Black or African American subjects was roughly in line with the current US population estimation of 13%. Looking at the clinical characteristics, participants with AFC less than or equal to 15 had a mean age of 36 years and a mean BMI of 27. Those with an AFC greater than 15 were slightly younger with a mean age of 33 years and a mean BMI of 27. These baseline characteristics show that the study population is representative of women seeking ovarian reserve assessment in real-world clinical practice, giving the confidence that the results are relevant to routine fertility evaluation. In this study, AMH cutoff of 1.77 nanogram per milliliter and an AFC cutoff of 15 were used to classify ovarian reserve. Women with an AFC above 15 were considered to have high ovarian reserve. Looking at the data, the Siemens and Beckman assays both show a sensitivity of about 90% and a specificity of about 51%, with a positive prediction value PPV of 67-ish% and a negative predictive value NPV of 83-ish%. The Roche assay showed a lower sensitivity of 77%, but a higher specificity of 71%, with PPV and NPV both around 74%. Importantly, the confidence intervals for the difference between Siemens and Beckman include 0, meaning there was no statistical significant difference between these two automated platforms in this study. In contrast, comparison involving the Roche assay either against Siemens or Beckman showed a statistically significant difference, reflecting the analytical bias we discussed earlier and its potential impact on clinical interpretation. Overall, this slide highlights that while all assays provide useful clinical information, variability between platforms could influence sensitivity, specificity, and predictive values, which is important to consider in practice when we interpret AMH results. This figure shows the ROC curves comparing the 3 automated AMH assays for discriminating ovarian reserve. Let's start with panel A, which shows the ROC curve for 3 AMH assays, Siemens Centaur in blue, Beckman in red, and Roche in green. As a reminder, a ROC curve plots sensitivity on the y-axis against 1 minus specificity on the x-axis across a range of cutoff values. The closer a curve gets to the top left corner, the better the test is at discriminating the outcome, in this case, ovarian reserve. What you can see here is that the three curves almost completely overlap. That means the assays are performing very similarly. The cutoff values that were applied around 3 and 2 are thresholds of AMH that help classify ovarian reserve. Now moving to the right panel. This table summarized the statistical comparison of those ROC curves. The key number here is the area under the curve, or AUC, which condenses overall diagnostic performance into a single matrix. AUC of 0.5 means no discrimination, and 1.0 would be perfect. The AUC values for these assays range from 0.81 to 0.82, so all are in the good performance range. The chi-square test and p-values tells us if the difference in AUC are significant. For Siemens versus Beckman, the p-value is 0.9, which indicates essentially identical performance. For Siemens versus Roche and Beckman versus Roche, the p-values are 0.2. And Roche's AUC is slightly higher, but not significantly so. So to summarize, all three AMH assays show good discriminations for predicting ovarian reserve, with AUCs around 0.8. And importantly, there is no statistically significant difference between them. This means that for this clinical practice, the three assays could be considered interchangeable. Putting together the key points about method differences across AMH assays. First, the Siemens platform showed very strong correlation with Beckman, meaning the results track closely with each other. However, compared to the Siemens assay, Roche reports value that are about 40% lower. This kind of systematic bias across platform is a reminder that AMH standardization remains a challenge in clinical practice. So, where does this bias come from? Several factors may contribute. The differences in standard traceability, or how the assays and antibodies are designed, which AMH isoforms they detect, or the matrix effect, or the potential analytical interference. All of this could influence absolute values reported by different methods. Despite those differences in numbers, what is important is that the diagnostic performance is comparable. Siemens, Beckman, and Roche all show similar sensitivity and specificity for assessing ovarian reserve. So the main takeaway here is, while the assays are not numerically interchangeable, especially Siemens versus Roche, their ability to discriminate ovarian reserve is essentially the same. Before closing, I'd like to acknowledge the contributions that made this study possible. First, I would like to thank our collaborators at Yale School of Medicine, Emily Shang and Joe Hooley, for their individual roles in collecting and providing samples for the study. I also want to thank Siemens for their support of the project. Their combination or the combined efforts were very important, and we are very grateful for the partnership that allowed us to carry this work forward. So next, I would like to hand over to Dr. Mark Borgman for summary.
Thank you so much, Dr. Li and Dr. Vitek. Wonderful presentations today, and it is so nice to hear a clinician and a laboratorian's perspective on fertility assessment. Lots of information was reviewed, and as we heard Dr. Vitek comment, providers are encouraged to integrate AMH testing into their clinical decision-making as an aid in the assessment of ovarian reserve. But also as a laboratory listening today, responding to that clinician need, it is also great to know that you can step forward into that testing with confidence in real-world data examples. Certainly, it is evident that data indicates superior performance as well as greater flexibility in the timing of sample collection for AMH compared to other hormone levels. And, as we see, despite AMH assays lacking current international standardization, the Siemens Healthineers assay shows a high degree of correlation and offers proven clinical performance compared to the AMH assays available on alternate platforms. So with that, I would really like to thank everyone for listening. And now I turn this back to Bob for the Q&A portion.
Dr. Borgman, thank you for your concluding summary there. You've done a wonderful job of bookmarking the front and the back. And of course, we're very, very grateful to Dr. Vitek and Dr. Li for these two very substantive presentations on this important topic. We're hearing the chemistry with great finesse and detail from Dr. Li and clinical considerations, of course, from Dr. Vitek. Now, I want you to know in the audience, you have plenty of time to make some comments or questions. Just type them in, and we'll get to them in a moment. In the meantime, I have a few questions that I wanted to ask of our speakers, and my first question is going to go to Dr. Vitek. When you're speaking with patients, how do you explain what the AMH level really means to them?
Yeah, the patients want a test that's going to definitively tell them if they're able to get pregnant or not. And while AMH is our most helpful tool in counseling, it's not a yes/no interpretation of the lab value. So I describe it as an egg count number or marker. It gives us a sense of how many follicles which contain eggs are developing at this point in time. I remind patients that the follicles replenish multiple times during a menstrual cycle. So if it's reflecting that there's 10 to 20 follicles, it's not their last 10 to 20 that they'll ever have access to. It's just the pool or cohort that's developing at this point in time. It's helpful to compare the AMH to age-based normative values to give a sense of how she is undergoing her ovarian aging process compared to other women of a similar age, but ultimately it comes down to egg quality, and age is our best predictor of egg quality in the absence of a test. Again, AMH is more quantity or number, but age most closely correlates with egg quality.
Thank you. Let me just have a quick follow-up on that. Many women, I'm sure, have read a lot about these issues as they enter into these kinds of consultations with you, and probably are very concerned about when testing needs to be done within their own cycle. So talk to me about is AMH testing, does that need to be done on a certain day of the cycle for a woman?
Yeah, that's the beauty of it. If they come into the office to talk to their doctor or provider, they're concerned about their fertility, the blood could be drawn that day, regardless of where they're at in their menstrual cycle. And that can help to make sure they get the information. Sometimes if we write an order for a blood level and then say call with your period or go to the lab on day 2 or 3, that presents a logistics challenge where not all patients will remember or follow through on. So an AMH can be drawn at any point in the menstrual cycle. It can be even drawn in women who are not getting their cycle because they're on long-acting reversible hormone contraception like an IUD, or if they're on birth control pills. The birth control pill may slightly lower the AMH, but that's something we can take into account when we're interpreting the value.
Okay, thank you very much. Dr. Li, I have a question for you. Whenever we talk about reference materials and WHO materials, we always have some questions. I think you've made a very excellent explanation of this, but let me repeat the question that we have here, which is, you mentioned the lack of an international reference standard as a challenge, but now that the WHO material is available, does that automatically mean we'll improve comparability across the platforms in the near future? Dr. Li.
Yeah, so that's a very good question. So the WHO reference material was an important step to harmonization, but it doesn't fully resolve the issue. AMH is a complex glycoprotein with multiple circulating forms. So while the WHO preparation is a recombinant version that may not fully reflect that complexity. So while it could help reduce some variability, it will not completely standardize the results across all the platforms. And we need to continue working on developing a true commutable reference material to meet the request for testing harmonization.
Very good, thank you. Now, I assume at a major center like the Ohio State in Columbus, you see a great many patients who are been referred in for further workup of their condition and their desire to become pregnant, et cetera. Do you find it easy or difficult as you're reviewing the lab results that they bring in with them to compare between the platforms as reported in their records?
Well, we sent out AMH testing before to a reference lab, and once we had the AMH assay available on our current platform, we did a thorough comparison study with the reference labs. So with that, we were confident to see very minimum bias between our platform versus the other the reference lab. So once we bring it in-house, we did not get any complaints or questions from the physicians about the testing.
Very good. Thank you very much.
Yeah.
Dr. Vitek, back to you for a couple of questions. First, we have a question regarding polycystic ovarian patients. We assume they have a more difficult time becoming pregnant. And if so, and in that case, would AMH measurement help these patients in your working them up?
Yeah, the AMH value reflects the antral follicle counts, and women with polycystic ovary syndrome have many arrested antral follicles. They have potential eggs that aren't being recruited into dominant follicles in ovulation. That leads them to have anovulatory infertility. They tend to be great candidates for an oral ovulation induction medicine called letrozole, which is an ACE inhibitor. And if they move into IVF, we can use the AMH to anticipate how to safely dose their stimulations so that we don't overstimulate, retrieving 30 or 40 eggs that can lead to the risk called ovarian hyperstimulation syndrome. So it can be a key part of their care. It's also could be part of the diagnosis of PCOS, though Siemens isn't like approved or studied for that indication, but the international guideline for PCOS does allow for AMH level to be used as a proxy for polycystic ovarian morphology, which is traditionally transvaginal ultrasound finding.
Okay. And just for those of us coming to it a little bit from the outside, you had two very interesting cases in your slide deck, and I wanted to ask you about them. The first was younger women looking for AMH levels, essentially as a benchmark. So they sort of know the time the clock is ticking, and the AMH level helps them know just exactly where that clock is. Could you speak a little bit about that? How frequent is that? Is that a fairly new thing in your practice, and it seems like it'd be a very sensible thing to do for a 33-year-old woman, as an example.
Yeah, I agree. It's become more common since 2012 when elective oocyte banking was no longer considered experimental because there was enough data about the safety of the process, the thaw rates, and the pregnancy rates that result from frozen thawed eggs using the technique called vitrification. So since 2012, the number of egg banking cycles in the United States has greatly increased as women are delaying childbearing. This is an opportunity or alternative to freeze eggs when their fertility is peak, but then revisit carrying the pregnancy at a time where it better fits their career or social situation. So I think it's a common conversation that many women are approaching their general OBGYNs, their family medicine doctors. They want to know this information, and getting an AMH is a key piece of information that allows for personalized counseling, not just the general, like, as women age, their egg count declines, their egg quality declines, you're best having your baby in your 20s.
I see.
Still good advice, but it's helpful to see the AMH because it helps the patient better understand. It's something that could be tracked serially over time. So if she is concerned and has a high AMH, maybe you check it in a year or 2 years and just follow the trajectory. But as in the case, it was unexpectedly low for her age, and her FSH and estradiol were reassuring. So those labs alone could have missed her diminishing ovarian reserve that would potentially have prevented her from getting her eggs frozen at a more optimal time instead of waiting a couple years.
Thank you. Thank you very much. This is a very interesting new area of clinical practice, isn't it? Fantastic. I'm going to come back to you, Dr. Vitek, with another question, really stimulated by your slide deck, but I'm going to ask the question first of Dr. Li, and that, of course, is something that all laboratorians are very conscious of. Women with cancers of all various types, and what it means for them for future pregnancies and future health. Dr. Li, do you find that that's a concern among many of your OB/GYNs at The Ohio State?
No, I don't think we got any concerns about the implementation of the testing. Yeah, so actually we did see the testing volume grow up after we bring this test in-house, and we're still keep monitoring the testing volume right now.
Very good, thank you. And Dr. Vitek, again, to go to your point, to preserving the eggs in patients with cancer, you're finding the AMH to be a very useful test.
Yeah, these poor patients their world is crumbling. They're finding out they have cancer. They may need immediate treatment that may impact their fertility. And then they have to make a decision about whether or not they want to undergo the stress of an quick IVF cycle before they get a port and start chemo or get radiation or have surgery. So having a biomarker that can be checked at any point in the menstrual cycle, the day they present to the office, I can check their AMH and instantly have a plan developed so that they can not delay. If I had to wait for their period to do a day 2, 3 FSH, estradiol, AMH, or antral follicle count, that could delay their chemo significantly and be a deal breaker for some patients and their oncologists. So AMH helps us expedite their care plan and also do it safely so that we don't have overstimulation, which could delay their chemo.
Thank you very much. On that very worthwhile note, and I think I'll give you the last word. It is wonderful as laboratory folks to have an assay available which can do so much good for a patient who's not always going to be in the best of moods and certainly has physical challenges ahead. So it's a kudo to Siemens and to those who have this test available for those patients and those patients generally. So thank you very much. I'll give you the last word. We're about at the top of the hour, so now I'm going to go ahead and wrap up, I want to thank Dr. Mark Borgman of Siemens Healthineers. As we just heard, I want to thank Dr. Wendy Vitek of the Boston IVF Clinic. It's a wonderful presentation, wonderful, hopeful, helpful news for patients. And finally, of course, I want to thank Dr. Li from the Ohio State University. Needless to say, I also wish to thank Siemens Healthineers. Their special educational grant allowed us to bring you this program. I hope you have enjoyed it. And the final thanks finally to all of you who've taken time out of your busy medical schedules today to join us. We're really grateful for you to join us, and we recognize that and thank you. So that's the final word. Dr. Borgman, Dr. Vitek, Dr. Li, to Siemens Healthineers, and to all of you. With that, this is Bob McGonigal, and I'll bring today's webinar to a close.